If someone's partaking in group sex, or if someone's using drugs in and around the time that they have sex, we sometimes call this chemsex. If someone's had a recent STI, so sexually transmitted infection, if they've recently presented and are needing treatment for chlamydia, gonorrhea, syphilis, I'd really want to have a discussion with them about PrEP. If they're worried about acquiring HIV, perhaps they're in a relationship where it's difficult or impossible to get access to condoms, to get their partner to use condoms. Any sex work, either paying for sex or being paid for sex, receiving gifts for sex. And also we touched on this before around if your partner is having sex with people residing in countries where HIV prevalence is high. Okay, so moving on. So I just wanted to give a kind of brief overview of all the kind of PrEP drugs that have been kind of invented or kind of approved by the World Health Organization. So in 2015 was when oral PrEP was first approved, and that contains tenofovir disoproxil with emtricitabine. But in some countries where you are, this might be tenofovir disoproxil with lamivudine. And then in 2019, the WHO hasn't actually recommended Descovy from what I can see, but I just wanted to make you guys aware that this was something which was another kind of oral PrEP medication, which contains tenofovir alafenamide with emtricitabine, and it's essentially the kidney and bone friendly version of the oral PrEP, which was developed in 2015. I don't believe it's available in Europe. I don't think Gilead, the company, put in an application for the EMA to approve it, so I don't believe it's available in Europe. In 2021, the WHO approved the dapavirine vaginal ring. So this is a vaginal ring which women can administer. And then in 2022, that's a few years ago, cabotegravir was approved for PrEP. This is a long-acting injection. And then more recently, you may have read on the news around another injectable formulation called lenacapavir, which is a long-acting injection. And I'll go into these in a bit more detail as well as we move on. So I just wanted to reiterate that whether you have tenofovir disoproxil with lamivudine or tenofovir disoproxil with emtricitabine, they're both interchangeable. And if someone, for example, was on the emtricitabine version in their previous country, they can absolutely switch over to the lamivudine straight away. They don't need to wear condoms for an extended period. It would be, effective, straight switch. Okay, so if you don't mind, if I can take you guys back to Mentimeter now, and I'm going to share my screen. So I would love to find out in your country what PrEP medication is available. And if you can put your country in the chat as well. So if you state your country and then say whether you've got, I'll put the list of names in the chat just as well. So whether you've got oral PrEP containing tenofovir disoproxil, whether you've got Descovy, oral PrEP, cabotegravir injection, or lenacapavir injection, or the dapavirine, if I can spell dapavirine vaginal ring. So I've just put the name of the drugs in the chat there. So if you can just pop in the Mentimeter, pop your country in, and then what PrEP drugs you've got available, if you know. Equally, if you don't know, that's also okay. Okay, so oral PrEP, tenofovir, emtricitabine, Belgium. Thank you. That's really helpful. That's good to know. Portugal, oral PrEP, amazing. I'm yet to see someone using the dapavirine vaginal ring. It's not available in the UK. In Finland, you've got tenofovir disoproxil. That's good to know. I don't know if we've got anyone on the call from Italy. I think Italy may have been one of the first European countries to start using the cabotegravir PrEP injection. I think it was only in Milan and I forget the other country in Italy. Oral PrEP and lenacapavir injection in France. Is that Francia? Which country for cabotegravir? I think it was only Italy that has cabotegravir injection. The UK, it's just been approved. Thank you. Yeah, so in the UK we've got oral tenofovir disoproxil and Descovy, that's TAF, and then injectable cabotegravir injection was just approved last week in the UK. But I think Italy is the only other country in Europe. Amazing. Okay, so we'll move on. So now, if you could just write in the group in the chat here. So, what population groups do you believe would benefit from HIV PrEP? I know I've touched on some of them in the presentation, but perhaps we've missed some. Perhaps you want to kind of emphasize some of the kind of key population or reason migrants are asking for PrEP as well. So yeah, any population groups you believe would benefit from HIV PrEP, either some of the ones I've mentioned already or any new ones I might have missed. I think we've got some people who are still joining the meeting. So if you're joining now, if I can ask you to log on to menti.com. I'll put the link at the bottom of the chat here, and then the code is 77934335, and I can see one response so far, but two responses. Brilliant, thank you guys. So I'm asking, what kind of population groups do you believe would benefit from HIV PrEP? If you can't access Mentimeter, do feel free to pop it into the chat as well if that's easier.
I can't seem to see the writings on the chat. Is it
Yeah, it's no, I've hidden it. I've hidden it so that people don't see what other people have written. I will reveal. I'll do the grand reveal in a minute though.
Okay, that's good.
I'll give it another few seconds to a minute just to let other people respond. Amazing, 4 responses. Thank you guys. Okay, so I'm going to reveal responses if that's okay, guys. Okay, so I think I'm just going to mute. Okay, so let's look at, so these are the kind of population groups we've identified would benefit from HIV PrEP. So we've got women experiencing intimate partner violence, migrants at risk and on the move, sex workers. Yep, definitely. So we've got migrant GBMSM, trans women. So we've got drug users, sex workers, MSM, migrant population, and then at Oasis, so we work with trans migrant women who are in sex work. Amazing. They are mainly undocumented and high risk of HIV. We've got high risk adolescents and young adults. Yep, young people, big one, definitely. And then we've got sex workers. We've got people who inject drugs. We've got people with multiple partners with inconsistent condom use. Definitely agree. Then we've got MSM, sex workers, people who have group sex, chemsex, people who have taken PrEP, people who have had a recent STI, travellers, recent travelling, who have had sex with countries with a high HIV prevalence. This is amazing. This is amazing. And then we've got some comments in the chat, some men who have sexual relations with other men or animals. Okay, interesting. That's a new one. That's a new one I've heard. Thank you. Brilliant. Back to the presentation. Okay, so okay. Okay, so I guess I wanted to kind of address the kind of myths and fears that PrEP is only for gay men, and this is all the kind of big international guidelines that I could find, and who they say is eligible for PrEP. So we've got the WHO guideline at the top, and they're all broadly similar-ish, but slight kind of wording differences between them. So with the WHO, they are suggesting anyone who is HIV negative at risk of acquiring HIV should have access to PrEP. This includes, for example, condomless sex, partners where the HIV status is unknown or they have a kind of detectable HIV virus, sharing injecting equipment, and it's based on risk, not kind of specific demographic groups. And so depending on behavior and risk of HIV exposure. And then when we move on to the EACS guideline, which is similar but slightly more detailed in the kind of populations that it lists. So it lists GBMSM, transgender individuals, but also heterosexual men and women. And it defines factors such as inconsistent condom use, a recent sexually transmitted infection, recent use of PrEP, and sex partners who are living with HIV but not virally suppressed. Then we've got the CDC, so that's the USA kind of guidelines, and apologies, please don't get offended while I pop some of you on mute. So then we've got the CDC guidelines. So the CDC kind of stresses risk related to specific behaviours within the last 6 months, such as having kind of condomless vaginal or anal sex, partner living with HIV, inconsistent condom use, a recent STI. But what's notable in the CDC guideline is it specifically mentions about pregnant and breastfeeding individuals. And finally, moving on to the Beaver Bash guidelines. So this is kind of the UK guidelines, which was recently updated this year. And the UK have really approached this with a much more kind of like focus on equity and access. So rather than listing kind of like criteria, they have stated that anyone that presents to a sexual health clinic needing or wanting PrEP should be given it. And they've also given some more general eligibility criteria that we should definitely be thinking about. Obviously, we've touched on the MSM and sexually transmitted. So I guess the overall message is that PrEP should be offered to everyone who's HIV negative, whose kind of behaviours and circumstances put them at risk of HIV exposure. And Tresor, so the WHO BEVA guidelines are most inclusive and not focusing on a risk group. And I agree. I'm going to give you a thumbs up, and you're more agreeable to this kind of guideline. I agree. It should be more inclusive and less restricted to a population group. Okay, moving on. So just wanted to give you guys a brief overview of the model of care of PrEP in the UK. So this is just kind of for your own awareness, but also if you did come across someone who was going to travel to the UK and they were already on PrEP, this is what you could advise them. We obviously all want to kind of meet the UNAIDS target, which was to end new HIV transmissions by 2030. So in the UK, PrEP is available from sexual health clinics, sexual health services, and it's been available in England since 2020. Scotland is always one step ahead of us. It's been available in Scotland since 2017, and it's been available in Wales since 2020. The way the funding works is kind of the local government pays for the PrEP service within the clinic, and it's funded through public health grants, and the medication itself is funded via NHS England commissioning. But the important thing I wanted to mention here is that it's to access PrEP from sexual health clinics is free. They don't need a registered address, they don't need a registered GP, kind of like family doctor, and their migration status is not confirmed or required as part of that appointment. So I just wanted to really stress that it's free, there's no address required. In sexual health, we have patients which often present and have these kind of like pseudo fake names, so they're not giving their real name. They don't need to give a permanent address or anything like that. And then we offer PrEP based on the kind of BEVA BASH guidelines, which I spoke about in the previous slide. Okay, so I'm happy to, I'm flexible with whatever you guys want. So we can go for a quick 10-minute comfort break. I can power on and we can finish a little bit earlier. Okay, we've got a thumbs up from Nawazi. Let's get cracking. Okay, so I wanted to explain the dosing schedule for PrEP. So, and I've kind of broken it down into guidelines as well. Apologies, we've got a bit, I've been in an open plan office. Apologies if you can hear a bit of background noise. Okay, so we've got the WHO guideline, which recommends daily and event-based dosing PrEP. So we've got daily PrEP, which is taking 1 tablet once a day. And then we've got event-based dosing PrEP, which we sometimes call 2-1-1, which is taking 2 tablets 2 to 24 hours before sex, and then 1 tablet daily for 2 days after sex. Now, the WHO guideline recommends the event-based dosing is only applicable for men who have sex with men. And then we've got the EACS guideline, which recommends daily and event-based dosing PrEP. The event-based dosing PrEP is only available for men who have sex with men or transgender women. Okay, then we've got the BEVA BASH guidelines. So this year we've been really kind of inclusive with our dosing in that anyone can take daily or event-based dosing. So daily 1 tablet a day. We recommend to start with a double dose because you get protection levels after 2 hours. And then for the event-based dosing, it depends on the type of sex you're having. So the 2-1-1 dosing, which is the 2 tablets 2 to 24 hours before sex, and then 1 tablet daily for 2 days after sex, that's for anyone more broadly, kind of generally men, but also transgender women, but anyone having receptive or insertive anal sex or insertive vaginal sex. And then you've got the 2-7 dosing, which more broadly is more for women, and that's basically taking 2 tablets 2 to 24 hours before sex, and then 1 tablet daily 7 days after sex. And that's for anyone having receptive vaginal sex or on PrEP due to injecting drug use. Hopefully that makes sense. Okay, so just wanted to break up the event-based dosing because this is a little bit more of a complex dosage regimen. So for women who have receptive anal sex, is 211 okay? I'm really sorry, there's so much noise going on behind me. Okay, so if a woman is only having receptive anal sex, technically the 211 might be okay. I would be a bit nervous. Are they for transgender women, yes, 211 if they're having receptive anal sex, but for a cisgender woman just having receptive anal sex, technically it could work, but it's not been trialed and tested in this population that way. And I would be thinking, are they just having receptive anal sex? Is there any chance they may be having receptive vaginal sex, in which case they would need the 2/7? Yeah, Trezors, go ahead.
Yes, my question is, usually we have the information that for women, the regimen they can use is the daily pill. So during 7 days and after 8th day, they can start the vaginal sex. But my question is, because we have received this question from some women on the field, before, if they want to rapidly have sex, but okay, they have the information that the vaginal sex is not possible until the 7th pill. So during the waiting time, is it possible for her to have anal sex or not?
Yeah, it's a tricky one.
Or if occasionally, if sometime also they don't want to have this daily pill each day, by occasionally they want to have anal sex, for example, is it possible to her to take the regimen 211 or not?
So if you're not in the UK, then you're not covered by the Beaver Bash guidelines who are recommending this dosage. So wherever you are, the EACS guideline will not be really recommending what you're saying. So the reason women have to wait 7 days to have vaginal sex is because the tenofovir levels take 7 days to get into the vaginal tissue. So that's why we've always gone by a woman starts PrEP daily, they have to wait 7 days, then they can have vaginal sex, and then they have to take PrEP for 7 days after. Now, in the UK guidelines, we've said women can start with a double dose and they can have whatever sex they want after 2 hours, vaginal or anal, but they must continue the PrEP for 7 days afterwards. So that's 7 days before. We've gotten rid of that, and we say women can start with a double dose and then have whatever sex they want. Now, this is UK guidelines, so I'm just nervous about you recommending this in your country, which isn't supported by your national or European EACS guidelines.
But in Belgium, I think we use EACS guideline.
Yeah, EACS guideline doesn't recommend what I'm saying with the double dose for women, but it's not been trialed and tested. So what Beaver Bash guidelines are recommending is based on what they've done looking at drug levels, and they see that the drug levels get into the bloodstream, with that double dose, and so it should be effective. So technically, if you're following the EACS guidelines, then I would say, I don't know. I don't know. I think.
But I think, in your opinion, technically, without EACS guideline or Bash guideline, scientifically, is it okay for women to have this regimen 211 for anal sex, or is not a way?
If they're just having receptive anal sex, according to our Beaver Bash, they can do 211.
Okay.
But if they're having vaginal sex, they need to continue the PrEP for 7 days after.
Yeah, sure. Yeah.
but just anal sex, they could double dose and then continue for 2 days after. But if they're just vaginal sex, in the UK, we would recommend a double dose and then continue for 7 days, like
Okay.
a quick start. Yeah. Is that all right, Trezors? Yeah. Jean-Paul, you've got your hand up.
Yeah, thank you so much for giving me the floor. I just want to follow the problem of guideline. So it was the same thing with the treatment about HIV, and the guideline was very different between Switzerland and France and another country. And how can we follow the same guideline with every country? The guideline that respect the science. So why is the problem actually? Yeah, that is my question. Thank you.
Yeah, I agree. It's frustrating. And I think it depends on the country to set their own guidelines. They can follow international guidelines like EACS and WHO, but the problem is that oral PrEP has not been trialed and tested enough in women using the event-based dosing. So that's why these guidelines are quite restrictive about using event-based dosing only in gay men or transgender women, because event-based dosing PrEP hasn't been trialed and tested in women enough. In the UK, we're kind of like extrapolating from drug level data, but technically, if I'm starting a woman on event-based dosing PrEP, I have to tell her, you know, this hasn't been trialed and tested with women, but we know that with drug level data, it should give adequate protection. So it's what we call it's an unlicensed kind of off-label way of using a drug, because it's not been trialed and tested, and it's not in the licensing to take the PrEP this way. But I did just want to give you the information about in the UK what we recommend, because it's possible the EACS and the WHO will see what Beaver and Bash have done and expand or kind of loosen their guidelines. So yeah, going into, got the 211, 2 tablets, 2 to 24 hours before sex, and then 1 tablet daily for 2 days after. And then moving on to the dapavirine ring, which it sounds like a lot of countries in Europe, which you guys are reporting, haven't been using this. We're not using it in the UK either, but I think it's good just for you guys to be aware, because you may have countries migrating from a country which does use it. So essentially, it's a medication in a kind of vaginal ring, which is inserted into the vagina, and it expels the drug dapavirine, which gives HIV protection. And the vaginal ring has to be inserted every month. So you would have to remove it and then reinsert a new vaginal ring each month. And patients can take it home, they can administer it themselves, they can also go into a healthcare provider and get it administered. So moving on to cabotegravir injection, which it sounds like possibly France have. I know Italy does. Oh no, sorry, France, you were saying you've got lenacapavir. So I think just Italy at the moment. The MHRA has approved it, so I think the EMA, the European Medicines Agency, hopefully will approve it soon. So cabotegravir is another kind of HIV drug. It's under the class of drugs known as the integrase inhibitors. And the way you take it is you can take an oral version of the cabotegravir as an oral lead-in, 1 tablet once a day for 30 days. And this is optional. Patients don't have to take this. The reason why I would say for a patient to take it is to check if they have any side effects to the drug. But if someone wants to take injectable PrEP because they can't adhere to oral PrEP, then that's not really that's perhaps not what you would want to do. You would want to go straight in with the injection. So whether they've had an oral lead-in or not, they start the injection. One injection is an intramuscular injection that you give into the buttock, into the bottom. So you have one injection and then you come back a month later for another injection. So it's a bit like a loading month. And then after your second injection, you move on to having the injection every 2 months or every 8 weeks. And then you just continue having it every 8 weeks. In terms of why is it vaginal ring, why is it not promoted in Europe? It will depend, I think, whether the Medicines Regulatory Agency, which I believe is the EMA in Europe, whether they've approved the vaginal ring or not, which it sounds like they haven't, because I think it's more kind of places in Africa have the vaginal ring and more kind of like underdeveloped countries, but it sounds like Europe doesn't. Trezors, yeah, do you want to go ahead?
Yes, because I think it's validated by WHO, who is, I think, an international agency. But I think in Europe, so as you say, in Africa, it's okay for women to use it, but in Europe, it's not the case. So for me, it's not a sense.
Yeah, I guess it's just so that you have awareness that this is a PrEP option in other countries. So you may have a woman come to you who's on dapivirine ring, who's travelled from a country that has it available, or they're travelling to Africa, for example, where it will be available. I guess it's just to give you guys awareness of the PrEP options. But yeah, I guess just because WHO has approved it doesn't necessarily mean Europe will approve it under their regulatory body. Yeah. And then for cabotegravir, yes, it's the same injection schedule whether you're a man or a woman, and cabotegravir PrEP is licensed for men and women, same dosage schedule, so you don't have to worry.
And after the injection, automatically the person can have sex, or we have some delay for waiting before to have sex?
Yes, good question. So it's 7 days after the first injection you have to wait.
Okay.
Yeah. So the oral lead-in, the oral tablets, they were trialed for safety, not effectiveness. So if someone's on the oral version of the cabotegravir, I would say use condoms. And then when they start the injection, whether they've taken the oral tablets or not, they need to wait 7 days from the day of their first injection before they can have sex without condoms.
Okay.
Yeah. The important thing to mention about cabotegravir injection is that because it's kind of like it's a long-acting injection, so it stays around in the body for a long time. So after you've had an injection, it stays in your body for 12 months after you've had the injection. So say, for example, you're on cabotegravir injection and you decide, actually, I want to stop it. It stays in your body for 12 months afterwards. So what the recommendation is, if you stop cabotegravir PrEP, you need another type of PrEP option for 12 months afterwards. Because if you come into contact with the HIV virus, that cabotegravir drug level is still there. Sorry, so the cabotegravir drug is still in your system, but at a small level, and it's not enough to fight the HIV virus. So you become infected with HIV, you've got a tiny bit of cabotegravir in your system, and that virus will develop resistance to cabotegravir. So when you come to treat the person for HIV, they're already resistant to cabotegravir. Cabotegravir is part of the integrase inhibitor class, which is one of the first line treatments for HIV, similar to dolutegravir, bictegravir, elvitegravir. And so that's why it's really important for the 12 months after you take cabotegravir, you either need to use condoms or use other forms of PrEP, oral PrEP, for the 12 months afterwards. Jean-Paul, you've got your hand up.
Sorry, just a short question. When you say after injection, the person should have sex after 7 days. Is
Yes.
automatically to have sex only after 7 days? If the person by error have sex after 6 days, it's dangerous or why?
Well, the problem is that the cabotegravir drug may not be high enough to fight off HIV infection. So what they're saying is that when you have the cabotegravir injection, it takes 7 days to get to the effective levels of HIV prevention. So if you're having sex between day 0 and day 6, the cabotegravir injection levels aren't high enough to fight infection. So you may acquire HIV, and again, you may also acquire a resistant HIV virus because that cabotegravir drug level is not high enough to fight infection, but it is high enough to maybe cause a resistant virus. Does that make sense, John-Paul?
Yeah, I think so that some more effort should be done when communicate with people to let them know that it's on their own on their own favor. So to make sure that they should respect the 7 day, I think.
Definitely, and that's part of the counselling that we do. So we've been giving cabotegravir PrEP for a couple of years in the UK under like a clinical trial, something called a compassionate access scheme, where the drug company gives you the drug for free as a kind of like a clinical trial to get kind of real world experience. So I've put about 2-3 people on cabotegravir PrEP injection, and that's part of the counselling that I'll do. I'll say, look, after this injection, you need to use condoms for 7 days. And about the PrEP window 12 months after as well.
Okay.
Any
Thank you.
more? Yeah, no worries. Any more questions about cabotegravir, Dennis?
Yes. So it's a bit. So you're saying that the drug levels. Obviously, if you have an injection this month and maybe a month 2, and then you decide that you don't want to use PrEP anymore, you know, how fast does the drug levels drop in your body? I mean, because you say, 1 year, but obviously, the curve probably will go down. So I'm just kind of interested in measures. So like yourselves, clinicians, what measures do you have? And maybe this is for treatment, but for PrEP, what measures do you have for the tail end management of something like that? Like you've talked about switching maybe to another PrEP, but if someone just doesn't want to use PrEP anymore, probably what is the recourse? Like what would you advise as a clinician?
Yeah, so after you've had month 2, that would be protective for 2 months. So
Okay.
after 2 months, you're going into an area where it's not going to be protective. So after you've had an injection, you've got 2 months where you're protected by HIV. After that 2 months, the levels aren't high enough. So if they don't want to take PrEP, I would say they use condoms, because if they're having condomless sex for that year after the injection, they could acquire HIV, and that HIV virus may become resistant to cabotegravir, and then they can't use any integrase inhibitor when they come to their HIV treatment. That's an issue.
So the practicalities of it is that if someone stops like in 2 months, obviously, do you have the resources and capacity to be able to give that person an appointment to check, sort of like the blood, so the levels of the drug? What I'm just saying is, that tail end management, what does it take in practice? Like what happens? How does someone know it is cleared, and how many tests do they have to, how many appointments do they have to come for example, to be able to check this at what intervals, just until they know it is clear?
Yeah, I mean, we don't do drug level monitoring when they come off the drug. That's not available. You can offer them HIV testing when they come off. Equally, like we recommend a lot of patients to do the at-home sexual health tests, the postal kits, so they can do that. But if we've given them cabotegravir injection, we would offer follow-up for HIV testing in that year that they come off, and we would offer an appointment to give them other kinds of PrEP. In reality, Dennis, with a couple of patients that I've had stop this injection, one moved to another country and stopped, so it's difficult for me to monitor that. And the other patient was in a monogamous relationship and didn't need PrEP for those reasons, so they haven't been monitoring them. So I think we're thinking that people are stopping the cabotegravir PrEP because of side effects, which may happen, but I think a lot of people will stop because they actually don't need PrEP anymore because their circumstances have changed. But also, just to provide some reassurance, is that in the trial data, when people stopped cabotegravir PrEP and in the year afterwards, when they acquired the HIV virus, no one developed resistance. So the trial data actually has been quite safe, which is good. But also, just to mention importantly, that even if people attend their appointment every 8 weeks for on-time injections, they can still acquire HIV. And there was 4 people in the cabotegravir trial, GBMSM, who acquired HIV with on-time injections to cabotegravir. So it's not 100% effective against HIV.
Okay, well, that's for out of how many people tried? How many people participated in the trial?
So that was 3,500 people. GBMSM were on that trial. But I think they were randomized half to injection and non an oral PrEP. So that's what, like 1,000, about just under, yeah.
All right, thank you.
Yeah, no worries. Yeah, Trezors, you're asking about how many countries give access to cab PrEP in their healthcare system. So I think it's only Italy, Trezors, and it looks like when people were commenting in the chat about what PrEP they have available, it was only oral PrEP. So I think it's just Italy and the UK at the moment, but it is it's available in the US. They've been using it in the States for a while. Okay, cool. I'm just conscious of time. I thought I wouldn't have enough time to fill this session, so let's move on. So lenacapavir is the other injection, which has been kind of publicized on the news quite a lot, and people get confused. They think it's a vaccine, but it's not. It's an injection, HIV drug for prevention, and it's a 6-monthly injection, and it's called lenacapavir. And it's a subcutaneous injection that you have like in the abdomen, and the way you take it is it's 2 injections that you have at the same time, and you take 2 oral pills, and then on day 2 you take 2 oral pills, and then 6 months later you take an injection and just continue the injections every 6 months, no more orals. Please don't ask me complicated questions about this because we don't have it in the UK. I have no experience using it. I don't know the lead-in time to when it becomes effective in terms of HIV protection. I know that they've put in an application to get it approved in the UK. It sounds like France has it in potentially, but I think this is coming, and I think if we can offer a 6-monthly injection for PrEP, this will be a game changer, and so I am really excited about it. The other thing with this, which is beneficial, is it hasn't got the same resistance implications as cabotegravir, because no one uses lenacapavir for HIV treatment. Lenacapavir is like 5th, 6th line. If you have like a really resistant HIV virus and you failed all other treatments, do you go on lenacapavir? So this will be great. Okay, now moving on to side effects. So I wanted to kind of address the myth and fear that PrEP damages the kidneys. It does affect the kidneys, but it doesn't necessarily cause the really toxic effect to the kidneys that some people worry about. Okay, so your oral PrEP that it sounds like all of you guys have available in Europe, the tenofovir disoproxil-based PrEP. Most of the side effects related to PrEP are because of the tenofovir agent. It's not the emtricitabine causing it, it's the tenofovir causing it. And the most common side effects we see are the stomachy type side effects, so the gastrointestinal side effects, things like nausea, vomiting, diarrhea, bloating, flatulence. We say take the PrEP with food. That helps to build up a tolerance. If someone's taking PrEP daily, they're more likely to build up a tolerance because the longer they're taking it daily, the body gets used to it. If they're on event-based dosing, the 2-1-1, you may get more side effects because that double dose at the beginning might be more of a hit, kind of more of an impact for the body. You don't necessarily have to take those 2 tablets together. They can be taken apart as long as they're within the 2 to 24 hours before sex. So say, for example, if someone was having sex tonight at 8 o'clock, they've got to get 2 tablets in before 6 p.m., 2 hours before they have sex, but they could have a tablet at 8 a.m. and then at 2 p.m. it could be split up so that it doesn't cause so much of an effect. The kind of central nervous system side effects we see in terms of headache, dizziness and insomnia, that's less common. We say take it with food. Sorry, not because of that. We say you can take normal painkillers. Paracetamol is fine. And insomnia, we sometimes say try taking the PrEP at different times of the day, and that can help. So those are the short-term side effects, which patients usually build up a tolerance. The longer-term side effects are with the kidneys and the bones. And again, this is the tenofovir disoproxil, which is causing these effects. And it's chronic kidney disease that PrEP causes. So it's being on PrEP for really 10 to 15 years of daily PrEP before we see problems with the kidneys developing. But we were only really worried about the kidneys with people with risk factors. So apologies, I've done kind of abbreviations there, but risk factors for kidney disease are things like age, high blood pressure, diabetes, or if they're on other nephrotoxic drugs. So things like ibuprofen, the non-steroidal anti-inflammatories, can be quite toxic to the kidneys. The other one is bone mineral density. So tenofovir disoproxil can reduce the bone mineral density in your bones. So it makes your bones less heavy and prone to fractures. And so you'll be prone to osteoporosis. But again, we're not so worried about this unless you've got risk factors for developing osteoporosis. So that's kind of like your people under 18, or your people over 50, or your postmenopausal women. Okay, moving on to tenofovir alafenamide. So this is an oral PrEP. It's Descovy PrEP. The tenofovir has changed, so we've swapped tenofovir disoproxil to tenofovir alafenamide. That makes it kidney and bone friendly. So this is what we use in the UK for people with chronic kidney disease and osteoporosis. It has a similar short-term side effect with the nausea, vomiting, diarrhea. There is a potential of weight gain, tiny bit of weight gain with Descovy. We see kind of about 1 to 2 kilos in the first year, and then it kind of plateaus. Moving on to cabotegravir, this is the injectable 2-monthly intramuscular injection every 8 weeks that we talked about. And the main side effect people get is injection site reactions. So kind of like pain and soreness in the buttock and the muscle where it happened. Diarrhea is also a possible side effect. And we are seeing, and this is common amongst the kind of integrase inhibitor drugs, the kind of dolutegravir, raltegravir drugs, are these kind of mood changes, a bit of low mood or anxiety. And we're also seeing potentially a bit of weight gain as well. With the lenacapavir, we haven't got experience using it much, but they have been using it in America a lot. And again, it's the injection site reactions, which is the most problem. So it's a subcutaneous injection in the abdomen, which can cause a bit of pain, redness, swelling, and it can cause a bit of a lump, which we sometimes call nodules, which can be painful, and it can possibly cause nausea as well.
So the injection on the stomach area, is it the stomach area or something?
Exactly.
Under the skin.
Yes.
Under the skin.
So you might like pinch the skin a little bit around the stomach and then inject it into the skin.
Okay.
And then the dapaverine ring has very little side effects because it's kind of delivered locally in the vagina, but it can cause urinary tract infections and some kind of like itching and inflammation around the vagina and possibly pelvic pain. Just moving on quickly to drug interactions. So if you guys haven't seen already, I've put the QR code here, and I think I've sent the slides to Nawalzi and Dennis so they can share this with you afterwards. You've got the Liverpool Drug Interaction website, which is available in a few different languages as well. So you can put in the drug PrEP, the oral PrEP, tenofovir disoproxil, and then you can put in whatever other drug the patient is on. And there's a lot of herbal and multivitamins and that herbal remedies which have been added on, which is great. Just to go through the main drug interactions that we worry about. So I mentioned with tenofovir disoproxil, the main drug interactions are any drugs which also affect the kidneys. So it's not that ibuprofen and PrEP interact, is that they both cause an effect on the kidneys and put pressure on the kidneys. Now, if someone's taking ibuprofen like ad hoc as and when they need it for pain, I'm not worried about that. I'm worried if they're taking ibuprofen 3 times a day regularly for weeks and weeks. That's going to cause pressure on the kidneys. And what I'd want to do is just make sure that they're having their kidneys checked. In terms of the dapaverine ring, it's very less interactions because it's locally administered. The main interactions around administering kind of like vaginal antibiotic or antifungal type medications, so like clindamycin, metronidazole or clotrimazole, like pessaries or vaginal cream. There's a potential that it can reduce the effectiveness of these vaginal creams. Moving on to lenacapavir. Lenacapavir does potentially have a few interactions, and this is because lenacapavir is metabolized by a enzyme which other drugs can affect the kind of metabolism. So people taking cholesterol type medications, statins, can interfere. People taking drugs for epilepsy, people taking St. John's wort, which is a herbal remedy we sometimes see people taking, or TB medication. TB medication interacts with everything. So if you ever see someone's on TB medication, big red alerts, check drug interactions. Okay, cabotegravir PrEP, again, it's the same as lenacapavir in terms of the St. John's wort, the anti-TB medications and the anti-seizure medicines. With the oral tablets for cabotegravir, I mentioned it had an oral lead-in. That has a potential interaction with the metals, metallic type supplements, anything that contains calcium, magnesium, aluminium, iron or zinc. Basically what happens is the calcium binds to the cabotegravir in the stomach and stops it from being absorbed. So you just have to wait 4 hours between taking these together. PrEP monitoring. So I mentioned about HIV testing. We do HIV testing. No worries. Thanks for joining. We do HIV testing as a 4th generation antigen antibody test. This is done before starting PrEP. And we do screening for the kind of most common sexually transmitted infections. That's gonorrhea, chlamydia and syphilis. For kidney function tests, we do something called a serum creatinine, which measures a result which looks like an EGFR, which is the estimated glomerular filtration rate, which basically tells us how quickly and well the kidneys are filtering medicines, toxins, blood. And then we also check hepatitis B and hepatitis C. And then we would do HIV and STI screening every 3 months while the person is on PrEP. And with their kidney function, it depends on their risk factors. So if they're kind of like under 40 years of age with good kidney renal function, no comorbidities, we can check their kidneys every year. If they've got if they're over 40 years of age or they've maybe got diabetes or hypertension, we'd check the kidney function every 6 months. Okay, and then just wanted to quickly show you a patient journey. This is what This is kind of what we expect in the UK. I think it will be something similar, I'd imagine. So someone would identify themselves as needing PrEP. They would then present themselves to a sexual health clinic in the UK. They would either walk in, or some clinics offer bookable appointments online. The appointment is then booked. There is an option for something, we use something called Language Line here, which where we can telephone translators, so we can use that kind of telephone translation service in clinic appointments if the patient's first language isn't English. And then at that appointment we have a discussion around PrEP. So we would discuss with the patient if they're eligible for PrEP. We'd talk to them about what PrEP is, how to take it, the side effects, and we would ask them some more confidential, personal questions, if you like. So we'd talk about sexual history. So we'd be asking the patient, how many partners are they having? What kind of sex are they having? How often? And we'd go into what's their past medical history, what's their drug history, and also social questions around mental health and domestic violence. And then we'd do all the monitoring. So we'd do, like I mentioned, HIV, syphilis, chlamydia, gonorrhea, hepatitis screening, and kidney function test, which are all blood tests and some swabs and a urine test. And then we'd give them the medication and they'd be on their day. Okay, finishing up here now, guys. So I just wanted to highlight the kind of key messages, the key take-home messages with PrEP. So I guess really reflecting on what is the key information the person you are speaking to wants and needs about PrEP. PrEP isn't just for white GBMSM, it's also for Black women, it's for non-binary and trans communities. It's extremely effective, almost 100% when it's taken correctly. In the UK, it's free. There's no migration check status. There's no address status. There's no registered GP that's needed. And it's free in sexual health clinics, and it's all confidential. So all their records that we write can't be seen by any other healthcare professional or GP. We know that PrEP is having a huge impact on new HIV diagnoses, but we also know that it's we don't want someone to take PrEP if they're already living with HIV, because we don't want to develop a resistant virus by giving them PrEP. So it's important that we do the HIV testing before they start on PrEP. PrEP does have a few side effects, but most of them are minor, and the kidney function problems that I talked about are reversible. So when you stop PrEP, the kidneys do recover. PrEP can be used in pregnancy and breastfeeding, and it can be used alongside contraception as well. And for trans people on hormone therapy, it can be used safely with hormone therapy. Most people can take PrEP as a daily pill, but event-based dosing can be used as well. And PrEP isn't necessarily for life. It can be for a short period in time when the person is at risk of acquiring HIV. It doesn't protect against pregnancy or other STIs, so PrEP is just for HIV. And PrEP is just one of the options. We talked about condoms, we talked about PEP and U=U and testing. So it's a combination of HIV prevention. Okay, so I'm just going to take you back, guys, quickly back to Mentimeter, and this is the last bit of our session today. So if I can ask you to go back onto Mentimeter. Okay, so if I can ask you now to fill in again, how confident do you now feel in explaining PrEP to someone who's never heard of it? Please enter your responses now. Do we need more time? Are we okay? I will show responses. Okay, so I feel like at the beginning there was a few not so confident, slightly confident. Now we're definitely moving more into confident and extremely confident. So that makes me very happy. Thank you guys. Okay, brilliant. So I'm just going to leave you with this slide on the screen. Oh, bear with me a second. Okay, so I've got some resources there for you as well. So we've got all the guidelines I talked about. We've got the ECDC surveillance data, and then some information booklets as well, which is really helpful. And then lastly, I've got just a feedback form and my contact details at the bottom there. So I'll pop the link in the chat as well. But if people have a chance just to fill in this feedback form, I would love your feedback and any kind of improvements, suggestions. I'll be very happy to take them. And we've got a couple more minutes now. We've made it to time, so that's amazing. Feel free to take yourself off microphone, pop your hand up, pop any questions in the chat. I'll be around.
I'll let Trezor go first.
Yeah.
Okay, thank you, Dennis. Yes, it's just a comment about PrEP. So I think it will be good to have all these kinds of PrEP, oral PrEP, injectable, and so on. But for me, the problem and the challenge is the access. If these all tools are available, but the access is difficult for the gay population, for me, it not be useful to have an impact of the HIV epidemic. So I think we must do an advocate to play with the company pharma to in the negotiation with the country to give this medicine available for the population. So without that, for me, okay, we have the tool to decrease the HIV epidemic, but due to problem of access, we have not an impact.
I 100% agree. There's no point having these wonderful drugs if no one can access them. There's just no point. And it's in the inequity is just not fair either. Why do some countries get access and others don't? And why do the countries that maybe have the not as much high HIV prevalence get them, where countries with which the highest HIV prevalence don't have access? It's not equal. And yeah, I think we can do as much as we can, but also it's up to the government and policymakers in the country where you are to make sure that PrEP is accessible to migrants, to everyone, and that it's free.
Yeah, so just to, I know we are at the top of the hour, people are going. So I just want to take this opportunity, obviously, to say thank you so much, Steph. I've learned a lot, despite the fact that I've been in this area for quite a while. I think that was a very, very fantastic presentation, and I do hope others agree that it was very, very insightful, and yeah. So thank you so much. And I hope that we're going to continue working together. Probably in the future, we're going to run a few more sessions like this. But yeah, it's been fantastic. So just keep engaged, and we will look forward to working with you. So please do fill in that survey, and of course Steph's emails and contact details are there. So yeah, great. And I also just want to take this opportunity to thank Nulwazi, whom some of you have met. She's hiding behind the camera somewhere, but she's done a fantastic job to get all this together. So thank you so much. And of course, my colleague Hala, who is always very, very helpful in this case. So thank you so much. I don't know if there are any other burning questions, but if not, I'll just bring the session to an end. And I think Nolwazi probably has an announcement for next session. Hello? Is she there?
Thank you, Dennis. Thank you so much, Stephanie, and thank you everyone for joining. And thank you so much for your participation and for engaging in the session. We really appreciate. We have our session next week on Tuesday, but our time is changing for next week. Our session will be at 3:30 CET next week. We'll see you there. I'll send more details pertaining to this session tomorrow and a link. And thank you for your understanding with today's technical difficulties. Thank you. Thank you,
Amazing.
everyone. Turning your
Thank you,
camera
guys. It's
on.
been an honor.
Okay.
Bye.
Bye-bye, everyone. Thanks a lot. Bye.
Thank you. Bye.